अहमद आ गया? Bismillahirrahmanirrahim. Assalamu alaikum, everyone. First of all, I'd like to thank the organizers, especially Professor Jawad Ansari Saab, for inviting me here to talk about the malignant pleural disease. And thank you, Professor Farhan, for your excellent presentation. So I'd like to start my presentation with a 35 years old patient who was a never smoker. He presented with cough, exertional dyspnea, hemoptysis, and weight loss. He had a strong family history of malignancy. His mother died in a younger age with an ovarian malignancy. And this is the chest radiograph. You can see a large opacity on the right side with ipsilateral shift of the mediastinum. Now, this patient was a young patient. He was a milk seller. He was from a village near Okada. And he also had history of bronchial asthma that was just seasonal. So initially we thought that this could be bronchopulmonary aspergillosis and there may be a large mucus plug in the right main bronchus. But to our surprise, there was a large tumor that occupied the right main bronchus completely, and that led to complete collapse of the lung, and it was an adenocarcinoma. So we did electrocautery and organ plasma coagulation to debulk the tumor. And this is the post-procedural radiograph, much clearing of the radiological opacity with right hilar mass is still there. And during the course of the treatment, the patient again came with an opaque hemithorax, and this time it was a large pleural effusion. So you can see the pleuroscopy, the diaphragm, which is studded with malignant pleural nodules, the anterior pleural zones, all three lobes of the lung. You can see the fissural nodules, the fluid, and a lot of nodules in the posterior pleural zones. So this was the medical thoracoscopy showing everything on the screen, on the video, and then you can do the directed biopsies. And this is the post-procedural radiograph. You can see the chest tube in. Once the lung was completely expanded to the chest wall, we did the talc pleurodesis, and the drain was removed successfully. This led to significant improvement in dyspnea. We all see patients with malignant pleural effusions. They are not uncommon in the pulmonary clinics, as well as they also go to the surgeons. So I'd like to discuss the diagnosis and management. We all know the aggressive neoplasm, malignant pleural mesothelioma, which is a neoplasm which has a strong association with asbestos exposure. I think people in KPK, they see more of these masses, these malignant disease of the pleura. And it is quite an aggressive tumor. It originates from the pleura, and then it can involve the chest wall, the diaphragm, the mediastinum, and it has a very high mortality. Apart from this, there are a few more primary pleural neoplasms. Primary means they originate from the pleura, like sarcoma, like solitary fibrous tumor, epithelioid hemangioendothelioma, lymphomas, and some of the benign tumors. But the commonest malignant pleural disease that we all come across are from the metastasis. So theoretically, any malignancy in the human body can metastasize into the pleural space. In some of the patients, you may see dry pleural metastasis or the frank mass lesions, but in majority of the patients, the malignant pleural effusion is seen in the pulmonary OPDs. Some of these patients, they are hospitalized because of the worsening in their dyspnea. So my topic is going to be on, my discussion is going to be on the malignant pleural effusion. Approximately 15% of all patients with cancers, they develop malignant effusions, with lung and the breast cancer being the commonest ones to metastasize into the pleura. The expected survival in these patients is around between 3 and 12 months. The survival, again, depends on various factors, including the nutritional status of the patient, the stage, the aggressiveness of the tumor, the chemo-responsiveness of the tumor. But generally, the survival is poor. Median survival is around 4 months, especially in patients with bronchogenic carcinoma-associated pleural effusions. So what we need to learn from this is that we should be doing a procedure that should consume less time. These patients, they should be managed and discharged as early as possible so that they should be spending time with their families. The most bothersome symptom, we all see such patients, and these patients, they present with dyspnea. Or ये dyspnea is quite bothersome, and it is because of the volume of the fluid that lies over diaphragm. Now, if you perform an ultrasound, you will see inversion of the hemidiaphragm because the volume of the fluid is equal to the weight of a newborn, 2.5 to 3.5 kilograms, liters. So if this much fluid is lying over the diaphragm, you can very well imagine the intensity of the dyspnea. And once you deliver this baby, once you deliver this fluid, there is immediate improvement in dyspnea. This is usually the first question, how to make an accurate diagnosis. So the latest guidelines, the 2023 guidelines on the pleural diseases, when you suspect a pleural malignancy, one should consider a contrast-enhanced CT scan. हमारे यहाँ एक fashion बन गया HRCT, high resolution CT. Now, high resolution CT is very good for the parenchymal lung diseases, but if you want to see some neoplastic lesions in the pleura or in the mediastinum, then you should go for a contrast-enhanced CT. और प्रोफेसर अशरफ जमाल की इस पे बड़ी अच्छी presentations हैं about the CT scan. One should go for a therapeutic pleural aspiration in the first go and send the fluid for the cell blocks or the cytology, and one should consider doing the image-guided pleural biopsy. Now, the ultrasound-guided pleural biopsy in the hands of the pulmonary physicians, or it could be a CT-guided biopsy. And if you do an Abrams biopsy, a blind one, you will have less yield. But if you combine the Abrams biopsy with the ultrasound guidance, if you can see the nodules and you can biopsy over that, then you can have a very good yield with the Abrams needle biopsy. And medical thoracoscopy is very useful in the management of the malignant effusion. The thoracic ultrasound, CT scan, and PET-CT, they have got good sensitivity and specificity to pick up the malignant pleural nodules, and sometimes these investigations are complementary. आप ultrasound भी करते हैं, आप CT भी करते हैं. The use of the thoracic ultrasound in malignant pleural effusion, now there are a few signs that you can see on the ultrasound. So before you do your first needle aspiration, before you insert your first diagnostic or therapeutic needle into the pleural space, you can see the abnormalities. For example, you can see the nodules over the diaphragm, over the parietal pleura. You can localize the pleural masses. So you can see the collapsed lung, and you can plan your modality as per the anatomical abnormalities which are found in the pleural space. The history of ultrasound is quite interesting. We all know the Titanic disaster when in 1912 the ship sank in the North Atlantic Ocean. So this was the time when people learned lesson from this, and they developed the sonar system, the sound navigation ranging system, to detect the underlying icebergs and to detect the submarines. And from 1940 onwards, the use of the ultrasound waves was also done by the physicians to diagnose various disease processes. The studies have shown that the thoracic ultrasound by the pulmonologist is quick, safe, cost-effective, and helps to reduce the potential complications and also reduces the chances of dry pleural tap. So the thoracic ultrasound, they should be standard before doing any pleural procedure. Apart from many indications for the thoracic ultrasound, including the detection of the parenchymal lung diseases, the pleural diseases, the chest wall processes, one of the important indications to perform a thoracic ultrasound is to detect the presence of pleural fluid when the plain chest radiograph shows you a whiteout. Now, this was a patient who had a minimal pleural effusion, but it was a collapsed lung due to an endobronchial tumor. There are a few important contrast-enhanced CT scan findings which can help to detect the presence of the malignant pleural nodules. And it is important that the radiographer should know that there should be a delay of 60 to 90 seconds before you highlight the pleura. So the presence of the nodular pleural thickening, the mediastinal involvement, the pleural thickening greater than 1 centimeter, and the circumferential pleural thickening. They are very important, and they have a very high sensitivity and specificity for a malignant pleural disease. But sometimes you have a pleural disease which may show you an atypical histology. Professor Farhan Majid is sitting here. We had this patient, and you can see the reverse D-shaped opacity, the pregnant lady sign. And initially, we thought that this is a very loculated pleural effusion. And it was a dry pleural tap, so we referred the patient to Farhan Saab, and he did a thoracotomy of this patient and removed a 2.2 kilograms of a desmoid-based pleural tumor, and we could publish this as well. So what is the best management strategy in malignant pleural effusions? Now, one size does not fit all. It's not uniform. So in some of the patients with malignant pleural effusions who have a small and asymptomatic pleural effusion, तो उसको छेड़ने की ज़रूरत नहीं है. You can wait until it becomes symptomatic, but it must have been diagnosed precisely. Majority of these patients, they end up having symptoms, and the most bothersome symptom is dyspnea, where that can lead to orthopnea. But in a patient who is symptomatic because of a large volume pleural effusion, one should consider a large volume pleural tap up to 1.5 liter. And once you do this tap, you can see the symptomatic response to the drainage. You can see the ability of the lung to re-expand and the rate of subsequent reaccumulation, कि वो दोबारा कितने time में reaccumulate होता है. Now, in some of the patients where you perform the therapeutic pleurocentesis, the patient may come back in 3 days with dyspnea, with an opaque hemithorax. There may be a very rapid turnover of the pleural effusion, and you may find the large effusions. And in some patients, आपने एक दफा therapeutic tap किया, and then they may have reaccumulation after a month or so. So it depends. Systemic anti-tumor chemotherapy, you can involve the oncologist. Some of the chemo-responsive tumors, they may respond well, for example, patients with lymphomas. And some of the patients with non-small cell lung cancers, if they have the EGFR receptors, you may give the targeted drugs to treat the cancer as well as the effusion. So some of these patients, they may respond. Radiation therapy has a minimal role to treat the pleural effusion. Now, once you take the pleural fluid, over half of the patients, they have recurrence. 2/3, they recur rapidly within 1 month, and the remainder recur more slowly. And then there are various options जो हम avail कर सकते हैं. So in asymptomatic individuals, you may not require anything. This is very important कि आपने एक therapeutic tap किया, या आपने drain डाली, and then you see the expansion of the lung. Now, in some cases, the lung may not expand at all. हो सकता है ये इसी तरह ही खड़ा रहे. In some of these patients, they may have endobronchial tumors, and once you debulk the tumors, the lung may expand. Now, some of these patients, they may have a lot of septations. So in some patients, जहाँ पे lung की expansion नहीं हो रही, यहाँ पे जितनी देर भी आप tube रखेंगे, उतना ही patient को negative benefits होंगे. The reason is, if patient with malignant pleural effusion end up in an empyema, then you will increase the morbidity and mortality. And in the start of my talk, I told that we should be doing a procedure जो rapid हो, and the patient should be discharged as early as possible. So if this was my patient, I would tend to remove the chest drain if the lung is not expanding to the chest wall in 3 days. So when the fluid reaccumulates rapidly, patient has a better life expectancy and the lung is expandable. We are left with 2 options. Either we should insert a chest drain. ये वो patient है who is accurately diagnosed कि malignant pleural effusion है. The primary malignancy is well known. Then you can also either consider pleurodesis or you can do an indwelling pleural catheter. In over part of the world, we consider talc pleurodesis or chemical pleurodesis IPC, they have become default procedures in some of the centers across the globe, but unfortunately, they are not easily accessible in our country. They are very costly, and the rate of infection, the empymas, is very high. On the other hand, if the patient has a collapsed lung, then you can consider doing repeated therapeutic aspirations. You can send the patient home, and if the patient comes back with dyspnea, you can do therapeutic aspirations. This is, we are talking about the malignant effusions only. If there is failed pleurodesis, the patient has short life expectancy, then you can again consider therapeutic aspirations, but IPC is a viable option. Another important thing is to consider an early talc pleurodesis. Do not keep the tubes for longer duration of time. Agar 75% lung is expandable, you can still pleurodese these patients. Taaki upar se lung should adhere to the chest wall, there should be less space, and if the fluid reaccumulates, you may have minimal symptoms with that effusion. Cheaper options bhi hain. Talc is costly. Chinese talc jo hai wo thoda sasta mil jata hai, but doxycycline, bleomycin, and even povidone iodine, they are the cheaper options in those centers where the patients cannot afford to buy the talc. और एक और important चीज ये है कि it's not necessary that we should be doing a thoracoscopic talc poudrage, because talc is equally affected whether it is insufflated during the thoracoscopy or it is instilled as a slurry. There may be combinations. IPC plus talc को भी आप use कर सकते हैं, mechanical pleurodesis भी कर सकते हैं. Decortication, pleurectomy, and shunts, they are the procedures which have their own morbidity and mortality, and they are almost never done in patients with malignant pleural effusion because of the high morbidity, because ये patient fit ही नहीं होते इन procedures के लिए. Medical thoracoscopy is indeed a breakthrough in the management of the pleural disease, because monitor पे आप nodule भी देख लेते हो, and then you can directly target over the nodule. And in patients with malignant pleural disease, you kill two birds with one stone. You do the diagnostic component, the biopsy, and you also do the therapeutic component, pleurocentesis, fluid भी निकाल दिया, and talc pleurodesis भी आपने उसी वक्त कर दी. This was a 59-year-old female with carcinoma of the breast. She had an exudative lymphocytic effusion, cytology negative. And you can see the cause and effect relationship, a large mass in the breast, and then you have the enhancing pleural nodules. So this is the thoracoscopy. We inserted the thoracoscope, and you can see the lung, you can see the visceral pleura, which is covered with multiple various sized nodules. This is known as the pleuroscopy or the thoracoscopy. You evaluate the pleura, and you can see the parietal pleura, which is full of the malignant nodules, and then you biopsy the nodules and you take the whole nodule out. So medical thoracoscopy is a useful modality in the diagnosis and management of the malignant pleural effusion. You evaluate the pleura, then you evacuate the pleura. You take the directed biopsies, and as a one-stop shop procedure, you insert the spray catheter, and you can spray the talc during the procedure directly over the visceral and the parietal pleura. This is the radiograph, which is comparable, much better. Another patient, sometimes you have a small pleural effusion. Sometimes you may have nodules in the pleura. Now this was a 78-year-old male who was already on ATT. एक और problem ये होता है कि बहुत सारे patients unnecessary ATT ले रहे होते हैं, cytology negative होती है, ADA ज़्यादा होता है, और बहुत सारे patients हैं who are wrongly placed on ATTB drugs. Now this was a patient. Again, he came with this CT, HRCT. You can see the small effusion, but there was a mass just aside the aorta. We did a bronchoscopy first. Nothing was visible in the airways, and the interventional radiologist, he was reluctant to insert the needle in this mass. The patient just had a small pleural effusion. So what we did was, we induced an artificial pneumothorax. Air को हमने introduce किया. It's very easy. Intercostal dissection करके आप एक suction catheter अंदर डालें, and you ask the patient to take a few deep breaths, and you can hear for the hissing sound. Air goes in and out, the lung moves away from the chest wall, and then you can enter into the pleural space. And this is the evaluation. इसमें हमें pleura में कोई भी nodules नजर नहीं आए. You can see this is the suction catheter. You can see the fluid being sucked out. There are a few anthracotic patches only. over the pleura, और lung के ऊपर भी कोई nodule नहीं था. Parietal pleura पे भी there was no nodule visible. There was nothing. There were just anthracotic patches. So what we did was we evaluated the oblique fissure. We palpated it, and just below the fissure, you can see there are a few occult nodules. So ये subpleural nodules हैं जो आपको CT पे नजर आते हैं. So sometimes what you do is you just look below the fissure. If you don't find anything, you may find the visceral pleural nodules. So here you can see the nodules, they were clearly visible, and we could biopsy these superficial nodules. You can see the nodule was taken out. This is known as the pleural biopsy, and we also biopsied the anthracotic patch. This is the pinch and peel pleural biopsy. And again, the diagnosis was a metastatic adenocarcinoma. So in patients who have confirmed diagnosis of a malignant pleural effusion, patient is likely to benefit from an intervention. Fluid is amenable to intervention. There is a large volume effusion. The lung is expandable. Then you can do IPC plus talc, but in over part of the world, you can do chest tube and slurry, or thoracoscopy and talc pudraj. And in those patients जिनमें lung expandable नहीं है, lung trapped है, you can either consider doing therapeutic pleural aspiration or maybe an IPC. And if the fluid volume is small, you can still watch these patients. We had the medical thoracoscopy guidelines published in 2018. Professor Nadeem Rizvi is also sitting here, Professor Arshad Javed. So you can access these guidelines on the website of Pakistan Chest Society. Thank you.